quick thing before I moved on. Why did I call that ECG and not the EKG? Because it refers to an electrocardiogram, and in English, cardio starts with a C. Why is it EKG to some people then? Because the electrocardiogram was invented in Germany by a German who spells cardiac with a K. Let's talk about blood pressure. So, the reason that we needed to know the word systole and diastole is because we are going to detect systolic and diastolic blood pressure, and that's going to give us one value, blood pressure. Now, the heart is generating blood pressure, especially in the arteries, really, really close to the heart. The closer we can get to the heart, the more accurate of a blood pressure reading we can get. So we usually take blood pressure in that brachial artery, right there, because it happens to be very close to that heart. But still on a limb. That's the key part, right? So systolic blood pressure is going to be a higher number because it is the pressure of the blood against the walls of the blood vessels when the heart is in ventricular systole. So the heart is going and pushed all of the blood out into systemic circulation. So that's going to be the maximum pressure that you can experience. Diastolic pressure means it's going to be a low number because it's when you're in ventricular diastole and your heart is not currently ejecting any blood. We will detect these numbers with something I always have to enunciate and read like syllable by syllable, no matter how many times I say it. Sphygmomanometer. This is a sphygmomanometer. We have a cuff that we clamp around the brachial artery. And we are going to use a stethoscope, which is much easier to spell and pronounce. And we're going to listen to the blood vessels immediately distal to the blood pressure cup. What we are listening for is the point at which certain sounds, known as Korsakoff sounds, start and stop. When the artery is closed, there is no sound. When the artery has just opened, there's what we call turbulent flow. Blood is just making it into that brachial artery, past the resistance of the blood pressure cuff. So it's going to sound effectively like a sloshing. It doesn't really sound like sloshing, but that's what it is. It's blood hitting the walls and goes against the walls of that artery that previously did not have blood in it. At a certain point, instead of having turbulent flow, the flow is restored and blood can just rush through that brachial artery. So you no longer have those sounds when the artery is all the way open. You don't have that sloshing. Again, it doesn't really sound like sloshing, but that's what it actually is. So again, closed, no sound. Opening, turbulent flow, sloshing. All the way open, the fluid is going through effortlessly. It's not blocked at all, so there's no additional sounds. There's no special sloshing Korsakoff sounds. Therefore, when we measure blood pressure, we mark the point at which the sounds started and the point at which the sounds stopped. The point at which the sounds started means that there was enough pressure of the blood against the walls of this vessel to get past the resistance of the blood pressure cuff. The blood pressure cuff is pushing it down. But at a certain point, the pressure inside of the blood is enough to push back. And that's what opens that artery. So if you have very, very high blood pressure to push back, that means you're going to open that artery sooner. Likewise, if there's enough pressure in there for fluid to just completely resist that blood pressure cuff, that means there's quite a lot of blood pressure in there. So we used to say 120/80 was average. 120/80 is now the top of average, as I understand it. We've changed our understanding of those numbers a little bit. And we used to say it's desirable to be 120/80. Now it is 120/80 is really the max you want to be hanging out at. So again, 120/80 means you started hearing the sounds at 120, you stopped hearing the sounds at 80, because there was 120 millimeters of mercury pressure inside of your brachial artery when it managed to push through the resistance of that blood pressure cuff, and there was 80 millimeters of mercury in that blood pressure cuff, and therefore in your brachial artery, that allowed the blood to flow through clearly. I did not finish that strong. Okay, if you're over 120, over 80, we have varying degrees of hypertension, prehypertension, hypertension. And that is known as high blood pressure. It's the silent killer. You can have high blood pressure and be walking around and feel just fine, and then one day your kidneys fail. Or you have a stroke and you die. So it's the silent killer. It's a really, really common, what we call primary diagnosis in the United States, which means that when I say primary diagnosis, I mean that you have blood pressure without any other underlying health condition that would cause low blood pressure. Your blood pressure's high because you have high blood pressure, as opposed to you have high blood pressure because of a kidney problem, if that makes sense. So it's really common for people in the United States to just have high blood pressure for no other reason than they have high blood pressure. Lots of risk factors related to weight, lifestyle, also genetics. Hypotension is when blood pressure is too low. That would be me. Clinical signs, dizziness, and fainting are, and there's something called, orthostatic hypotension? Yeah. Orthostatic hypotension is when you stand up too quickly and get dizzy and almost fall over. That's orthostatic hypotension. What it means is your blood pressure is too low to keep up with supplying blood to your brain when you shoot up all of a sudden. Usually if you have orthostatic hypotension, there's an underlying health condition, if it's severe. If every time you get up you get dizzy, go to the doctor, get that checked out, because it could mean that there's some kind of plaque on the way to your brain that's making it harder for that blood to get to your brain. That's one reason that you might have that. So it's not necessarily that, oh, my blood pressure is just super low. It could be something clinical. If somebody has burns, you lose a lot of fluid when you have a burn. And likewise, blood loss. You're simply losing blood volume. And blood volume is very related to blood pressure. Here are some very major blood vessels, and it's a good way to conceptualize the heart as two side-by-side pumps. Respiratory circuits and systemic circuits, how you have one to your head and arms and another one to the rest of your body. It's a good visualization. I'll leave it, but let's focus on these. Okay, some important blood vessels. We're not going to do all of them. This is BIO127. I will track down a list for what you will actually be responsible for. I don't have that list at the time of this recording. One thing I want to point out is that, we just skipped the genitals, didn't we? These books are always so ashamed of genitals. It's part of anatomy, people. You're in an anatomy textbook. Include some genitals. Anyway, most of your arteries and veins are going to be the same, right? The branching pattern is nearly identical. So we're going to have a lot of overlap. For example, you're going to have brachial veins, and you're going to have a brachial artery. You're going to have radial and ulnar artery. You're going to have radial and ulnar veins, not listed here for some reason. And your major artery is the aorta. Your major veins are the superior and inferior vena cava. The major differences between these two systems are some extras that you get in your veins. So in addition to the brachial veins, you're going to have a cephalic and basilic vein. Notice you don't have cephalic and basilic arteries. In addition to the femoral artery and a femoral vein, you're going to have a great saphenous vein that goes all the way down here. You do not have a great saphenous artery. So largely in the venous system, you're going to have extras. You have common iliac artery, you have common iliac veins. Let's see. What do they do? It's not helping, is that? What else do I want to point out on here? I think I'm not going to point out everything on here. I think it's mostly just a list that you're going to need to learn, and I will get you that list. In the thoracic and abdominal regions, everything is named for what it is supplying. So that splenic artery is going to your spleen. That splenic vein is coming from your spleen. When we say mesenteric, we mean that there are mesenteries. Mesenteries are the connective tissue sheaths that envelop your small and large intestines, as well as some of the organs of your peritoneal cavity, your abdominal cavity. So everything's named after what it's supplying. Same thing with, let's see, do we have a hepatic artery labeled on here? No, that would be too easy. You should have a hepatic veins right here. So hepatic refers to liver. So that's your liver vein. Your hepatic veins are different from your hepatic portal vein. Hepatic portal vein is coming from intestines to the liver. Hepatic veins coming from the liver to the inferior vena cava. The arteries associated with the aortic arch are not symmetrical. The veins associated with your superior vena cava are symmetrical. If you need to remember these, it goes A, B, C, S, like I know my ABCs, plural. Aortic arch, right brachiocephalic, left common carotid, subclavian. Whereas this one goes bilaterally symmetrically, subclavian veins, brachiocephalic veins, superior vena cava. Way easier on the veins. Veins are almost always superficial to the arteries. There's that superior sagittal sinus. That was where we reabsorbed that cerebrospinal fluid. Here it is draining into your jugular vein. Back to your left brachiocephalic, because this is a left side view. What else do I want to tell you? One thing you may not see here, this femoral artery is going to rotate and go posterior to your knee. So in 3 dimensions, this is actually sneaking around back to the back of your knee, and that's why this is the popliteal artery right here. It's because this is a dorsal structure. This is in, this would be anterior, but by the time it's here, it's posterior. So that's not being conveyed by this image, but if you're trying to figure out why this is popliteal, that's why. This is also why we spent time on regional anatomy. I think that's all I want to say. That should do it. Some clinical relevance for some of these. Great saphenous, we used to always harvest this for bypass surgery. It is no longer the most commonly harvested for bypass surgery, but it's still clinically important. Okay. Regulation of blood pressure. Remember that chart I showed you with all the interrelated things and the whole section just for blood pressure regulation? It's a complicated thing, and we are simplifying it. You are very welcome. We'll make it complicated later. It's a complicated beast. There's a lot that goes into controlling blood pressure and a lot of safety mechanisms. Remember how common hypertension is. There's so many ways that your body can compensate for that, but at the same time, if your body's always compensating, it's stressful for your body to keep compensating. So, the important thing is that you have baroreceptors. Baroreceptors are a specialized sensory nerve ending to detect pressure. If you're familiar with weather broadcasting, barometers detect atmospheric pressure. So we have that baro in there indicating pressure. So you have this thing in your aorta and your carotid sinus, it's called, that detects how much fluid pressure there is against the walls of those blood vessels. Your heart also has some baroreceptors. It's kind of cool. It's like stretch receptors. If your blood pressure is detected to be elevated, the blood vessels are stretched. The baroreceptors detect that change. That signal is sent to the cardiovascular centers of your brain, which is in your medulla oblongata, by the way. The heart is signaled to lower heart rate and force of contraction. Guess which parasympathetic cranial nerve we're going to use for that? Probably vagus. It's always vagus. That's the key. It's always vagus. In addition to lowering heart rate and force of contraction, which again, your heart is generating blood pressure by pumping blood out into it, so that helps decrease blood pressure, but also if we can increase the diameter of the blood pressure, of the blood vessels, increase the diameter of the blood vessels, then we can reduce the pressure that it's under. So remember that pressure goes two ways, pressure of the fluid against the wall, pressure of the wall against the fluid. So we increase the size of the space, and now the fluid is under less pressure. So between vasodilation and decreased heart rate and force of contraction, that's our homeostatic mechanism that decreases blood pressure, if it's working. Now, final topics, cardiovascular disorders. All three of these are interrelated. Let's actually assume that this is one person across a lifespan. This person has probably a genetic predisposition to elevated LDL, so elevated bad cholesterol. They dumped a bunch of fat into the blood vessels of their heart, especially that left anterior descending, that left, sorry, it's not left, the anterior interventricular artery. Yeah, let's say that this is the anterior interventricular artery, also known as LAD. Cholesterol dumped a bunch of fat into in between the layers. The fat ends up, this is that endothelium, this is that middle layer of smooth muscle in the blood vessel. So here's the fatty layer. There's a lot more going on with atherosclerotic plaque development than just fat deposition. You kind of see here, we've got some smooth muscle invading. There's probably going to be some collagen in there. There's going to be some white blood cells that tried to clean this up and then got stuck. They're called foam cells. I think they're really funny. But for now, it's fatty deposition inside the tunics of the blood vessel. So, person has an unhealthy lifestyle coupled with their genetic predisposition to elevated LDL cholesterol. They haven't had their cholesterol checked in a while, and one day they wake up and they have chest pain, or they walk up some stairs and they have some chest pain for the first time. That's called angina pectoris, and it's a warning that there is not a complete blockage, a partial blockage. So some blood can still get through, and if you're just sitting around chilling, it probably doesn't feel bad. But if you increase the demands placed on your heart muscle, which happens with any kind of exercise, or if you're going up some stairs and it's a little bit more work on your heart to go up those stairs, that would be when you feel that chest pain. And that means that there's reduced blood flow to your heart muscle. Let's say you ignore that chest pain. It only happens when I walk up the stairs. I can survive. I'm not going to have that checked at all. That can lead to a myocardial infection, or infarction. I almost said infection. Even if you know about it, and you do treat it, and you lower your cholesterol and have lifestyle changes, this may not fully resolve, and you can still have a myocardial infarction anyway. It's called an MI. It's a heart attack. Now again, adult muscle cells are non-mitotic. Those cells die, they are gone forever. So myocardial infarction means blood flow has completely cut off to these cells. They are lacking oxygen, they are lacking nutrients, they become ATP depleted, all of their pumps fail, everything fails. Those cells die. Once those cells are dead, those cardiomyocytes are dead, they're not coming back. If they get replaced or healed, it's connective tissue. So that part of the heart can no longer contribute to the pumping of the heart muscle. Now, you can have a myocardial infarction that is minor. You can have a myocardial infarction that is severe. You can kill off enough muscle cells of the heart that the person dies. Or you can kill off a certain number of muscle cells of the heart and develop with a condition known as congestive heart failure, CHF. Now, that's not, oh, you have heart failure, you die. And this is something I see a lot in bad medical dramas or just colloquial terms that people use. Oh, he died of heart failure, or like a CSI type thing. Oh, he died of heart failure. No. Heart failure doesn't mean you drop over. Heart failure means that part of your muscle, part of your heart muscle, has died, but you still have the rest of your heart muscle working. So there's still some ability to move blood forward through your system. It's just less effective. And what happens is that things back up. They get congested. So a lot of fluid backs up in the system. We can't move blood forward, so blood stays backward. And that fluid, that blood pressure, where that blood is, pushes fluid out of the capillary bed, and we have edema. So that's the congestive part of congestive heart failure, is the edema, either in the extremities or in the lungs. And I can get into more detail about that. I teach this patho all the time. But that's the main stuff that I want you to understand, is you could live like that with severe edema, inability to do cardiovascular activities, decreasing cognitive ability. It can be progressive. It can keep going and getting worse and worse and worse. It could take weeks, it could take months, it could take years before you die of CHF, with a decrease in quality of life all the time. So of course, if somebody has angina pectoris, the best thing you can do is get that checked. And this might be a test that you have done. We might do some imaging to see if you have a normal anterior interventricular artery, or if you, or let's say this is a left coronary artery, or if you have an occluded coronary artery. And this is really common, really, really common. In every autopsy I go to, they cut into the coronary arteries and they write down how occluded it is. I was once at an autopsy of a 27-year-old woman, younger than me, who had passed away of unknown causes. They didn't figure it out during the autopsy, which is common. It's normal. But they did determine that both right and left, coronary arteries were 75% occluded at the age of 27. Normally, we would say that atherosclerotic development takes decades. In her case, it took 2.5 decades. So it was about that occluded. That would be what I would call 75% occluded. So again, these can be distinct, but they could also occur in the same person. You can have an MI without ever having angina pectoris. That it can be sudden. You can also go into something called vascular spasm. So if you don't want that to happen, there are some things you can change, there are some things you can't change. You can't change your genes. There are medications that you can take if your genes happen to make you predisposed to having elevated levels of LDL. Smoking, don't. Yeah. So again, one thing I want to say is that shaming people into making the right health decisions does not work. We've done the research on this, and me telling you right now, hey, you got to stop smoking or else you're going to die, it's not going to be effective. It doesn't help at all. We all know this. We all know that smoking is going to increase your risk of all number of things, including lung cancer, including cardiovascular disease as well. It's inflammatory. We've always used to think that atherosclerotic plaque development was just nutritional. It's not exclusively nutritional. We are finding there's a major inflammatory component to this happening. And that's the part that smoking contributes to, is the inflammation part of it. Same with diabetes mellitus, sugar, and the vascular endothelium, so the blood vessel lining. There's a really specific pathway that's pro-inflammatory for glucose in your bloodstream. So it actually causes an irritation to that vascular endothelium and really contributes to that atherosclerotic plaque development. So the more we control type 1 or 2 diabetes mellitus and keep blood sugar ranges in check and controlled ranges, the better health outcome we're going to have, not just for atherosclerotic plaque development, but also kidneys, eyeballs, feet, everything. Everything is vascular. So everything vascular can be threatened by any type of diabetes mellitus. Blood lipids monitor cholesterol levels. Again, there's LDL, there's HDL. HDL you want high, LDL you want low. And one thing about this, eating fats doesn't necessarily mean you're going to deposit that fat in your blood vessels. We thought that for a very long time, and it sounds correct. It sounds intuitive. You eat a lot of fat, you're going to have a lot of fat. that turned out not to be true. We put everybody on a low-fat diet, and people kept having more and more myocardial infarctions. We got more and more obesity rates. So we discovered eating fat does not make you fat in and of itself. Eating a lot of calories overall, a lot of sugars overall, those will cause you to store fats in unhealthy places, more so than simply eating fats. Fats themselves are not bad. Healthy fats are particularly good. Avocados, almonds, things like that are excellent for you. Eggs, probably pretty good for you, despite the cholesterol. Okay, again, blood pressure, treat your hypertension, get medication for it. I have a soapbox for that, but I won't get into it. Again, being overweight increases risk of heart attack and stroke, but again, if you are overweight, the best way to prevent cardiovascular disease is going to be to make healthy choices. If those happen to lead to weight loss, cool. But if they don't, it's still better for you to be eating nutritious food and getting moderate exercise, whether that leads to weight loss or not. And stress, avoid chronic stress, which everybody I know who's ever been in school is just like, yeah, nice try, Reeves. Okay, there's some blanks for you so that you can test yourself. Let me know if you have any questions. Thank you for your time.